Dear colleagues, dear guests, good afternoon. It's my great pleasure to welcome all of you to this webinar. I'm Dr. Rumiana Dimova from Medical University of Sofia, and on behalf of ESD Early Career Academy, together with Dr. Domenico Tricu, an assistant professor from University of Pisa, have the privilege to host this webinar organized by the Academy, with major credit to Dr. Caterina Conte, who unfortunately couldn't attend, but made the event possible to take place. So first, thanks all of you for your interest. It seems that the topic of the webinar is of high interest. And indeed, it's essential to understand how major clinical trials are developed, how we start generating a good scientific hypothesis, then collecting all the data accurately and precisely, and ending up with correct data interpretation and conclusions, and their implementation into future research as well as in the everyday diabetes care. But what is more important is to draw all this knowledge from the experts. So having this famous speaker in front of us, the meeting promises to be very interesting and to meet our expectations. So in order not to waste any more time, I hasten to give the floor to our guest, Professor Roy Taylor. Professor Taylor doesn't need any introduction since all of us know him quite well. He is a well-known physician, diabetologist, and researcher. He is a professor of medicine and metabolism at Newcastle University. He is the principal investigator of the DiRECT study. And he's gonna talk about how to direct understanding of type 2 diabetes into a major advance in clinical care. So I'm very much looking forward to his talk. So please, Professor Taylor, the floor is yours.
Thank you very much for that nice introduction. Good afternoon, ladies and gentlemen. I'm very pleased to be talking to you about this important subject. But let me start off with what you see in front of you, this picture. This is one of my main research tools. It's the town moor. It's a large expanse of open pasture land that is in the centre of Newcastle upon Tyne. I live on the one side of it, and every day I cycle over it. It's a great place to think. And thinking, logical reasoning, is one of the main attributes of a researcher. Just trying to sort out what really is solid information, what might not be quite so solid, and how we might actually test ideas. So I'll try and cover all of that in this lecture. But if we wind back the clock a few years, the view on the etiology of type 2 diabetes would have looked something like this. Type 2 diabetes is a complex, heterogeneous state. Now, in the background, you might recognize a metabolic map of the whole human metabolome. And if we look at all the details, it seems very complicated. But of course, what we're interested in is those aspects that have the biggest effect size, the important pathways. So let's try and dissect out some of the perhaps questionable ideas, and they're all around us. For instance, with the islet, investigators have suggested that it's amyloid building up, that there might be apoptosis, programmed cell death, maybe inflammation. Perhaps all these causes could be effective, even gut hormones. Well, how about the insulin resistance? Well, various causes have been suggested for that, some more likely than others, some extremely unlikely. The microbiota has enjoyed a burst of intense research activity, but really, after 25 years, there's no firm evidence. So let's just take a step back. I'd like to take you back to 2006 and before, when I was considering the cause of type 2 diabetes in the light of our research to that point. And it went something like this. We demonstrated that the liver was actually really very important. Hepatic glucose output was determining fasting plasma glucose. And the liver fat content absolutely determined the degree of sensitivity of the liver to insulin. So liver fat was really important. And high liver fat, well, there was liver insulin resistance. And then we came on to an interesting observation in 2006. Fasting plasma glucose was normal within 7 days of bariatric surgery. Now, that paper caused a huge stir, and when I read it, I smiled, because in the methods section, there was a clear reason why the suggestion of the authors that this dramatic change was due to a burst of incretins, this postprandial spike of incretin hormones after bariatric surgery, that could not be correct. Why is that? Well, these people had had a complete ileal bypass, the so-called Greenville operation. And that's a very major disruption of the gut. People are fasted for 7 days after surgery, and so fasting plasma glucose 7 days after surgery. There had been no incretin spikes. What had happened was a major drop in food intake. People who are having bariatric surgery naturally were quite large. They must have been consuming at least 2,700 kilocalories per day. That dropped very sharply at the time of surgery and brought about this dramatic change, which set me thinking, because perhaps we could, I get rid of that, perhaps we could look at the cause of excess fat as not only maybe causing the fasting change, but how about the beta cell? Could the fat be gumming up the works inside the beta cell as well? Well, putting all of this together, thinking about these issues as I cycled across the town moor every day, the twin cycle hypothesis gradually came into being. And it went like this. Excess calorie consumption over many years would cause accumulation of excess liver fat, causing insulin resistance, because we had shown that. But then there would be a vicious cycle, and the insulin resistance would cause plasma insulin levels to rise. That would have a knock-on effect in stimulating more fat production through de novo lipogenesis, which is happening only in the liver. And so there would be a vicious cycle. But fat doesn't just stay in the liver. It's exported to all tissues, including the pancreas. Now, lipoprotein metabolism may seem very complex. It's not. There's only one lipoprotein that's made by the liver, and that's very low density lipoprotein. All the other confusing lipoproteins are merely smaller versions of the same as its payload is shed as triglyceride is distributed throughout the body. But if it's exported to the pancreas, maybe the pancreas insulin production could be affected after meals, glucose could rise, causing more basal insulin to rise, and this whole cycle would be repeated. Now, that's just the overview, but you're specialists in diabetes, so let me take you into the details. The ideas that emerged on paper after many iterations was that positive calorie balance would produce too much liver fat. Now, I mentioned the de novo lipogenesis. Where does that fit in? Well, if people have got existing insulin resistance in muscle, which is largely a genetic phenomenon, of course, it's exacerbated by obesity and lack of physical exercise, but those are moderate changes around your genetic capacity. Now, if the muscle is insulin resistant, it can't store glucose as glycogen muscle glycogen after meals. That glucose has to go somewhere, and the only other pathway available in the human body is for it to be turned into fat temporarily. And that's what happens. So the glucose gets turned into fat as a function of the muscle insulin resistance after every meal, and the liver fat builds up. So we have the insulin resistance in the liver. Plasma glucose would tend to go up because of hepatic glucose production, and basal insulin secretion would rise. Paradoxically, that stimulates de novo lipogenesis. But then the fat, as we mentioned, doesn't just stay there. And if the subcutaneous stores are relatively full, then it's going to build up in the blood and be delivered to the beta cells. Now, we knew from rodent experiments beautifully conducted in the early 1990s by Roger Unger that chronic exposure to excess fat in susceptible animals would cause the decrease in acute insulin response. So now we're talking about acute meal response, not this basal, but the acute response. And that would cause plasma glucose to rise and the whole vicious cycle to begin to interact. Well, fine, but this is a hypothesis. And the only reason for setting out a hypothesis is to try and destroy it to see whether it's robust or not. Now, we could destroy this quite easily by taking very ordinary people with type 2 diabetes, turning that positive calorie balance into negative calorie balance, and measuring all these processes. So we devised the counterpoint study, which was approximately 700 calories a day. And what we found was glucose fell very rapidly, just like the bariatric surgery paper had pointed out, but this was purely a nutritional change. Now, the insulin response to meals was very sharply increased at 8 weeks, and here are the data. So, 2011, we were able to publish the counterpoint study. Note that it was on people with short duration diabetes. If you want to test your hypothesis, then you have to search for people who are most likely to fit the bill of what you're doing. We didn't want it to get complicated by inducing other factors. You'll see what happened when we stopped the drugs. Now, the concept of stopping drugs is something that would cause a sharp intake of breath by most doctors. Surely you can't stop these drugs. But hey, take a step backwards. What is the effect size of these drugs? It's actually quite small. So when we stopped the drugs and started the diet, which was up to 800 calories a day, look at this, fasting glucose normal in 1 week. And it stayed normal for the 8-week duration of this hypothesis testing study. This fall was due to the liver fat. Now, we had developed magnetic resonance methods for measuring fat inside the liver, fat inside the pancreas. They were revolutionary back in 2011, but now it's ordinary. Liver fat had fallen sharply. The fat in the plasma had fallen sharply. The liver insulin sensitivity had gone back to normal. So here we see the liver component of insulin resistance melting away. Not so the muscle. That was entirely unchanged. That is largely genetic. But slowly, over the 8 weeks, the beta cell function went back towards normal. This is an acute response, not completely back to normal, but improving. Dramatic data. And I just flag up that research is always a human story. And Dr. Elim Lim was the research fellow who carried out this challenging study on her own, just with my advice about how to administer the diet, how to stop the drugs. She actually pulled off this remarkable feat. This is a picture of the diet. We used liquid formula to have complete nutrition, apart of course from the calories. Here is one meal made up in a pint of water. Now, It's a good idea to keep the bowel happy and to have something to crunch on to eat, and non-starchy vegetables can easily provide that. So this is the original Newcastle diet that we used. And why use this? Well, it removes the difficult element of choice, which is so trying for people trying to lose weight. How much can I eat? Can I eat this? Is that a level spoonful? It's difficult. Well, here we had something where the choice was just the flavour of the packet. Remarkably, this was well accepted by people, well liked. The only difficulty was coming off the diet. And in the next study, we devised a steady stepped return to normal eating. So here we have the path to the big study. This huge enthusiasm, as I mentioned, by people with diabetes. When the Counterpoint study was published, I had such a huge influx of emails asking how individuals could do this, that I put all the information on our website. It's still on our website, updated of course. And then we had a second wave of emails from people telling us what had happened. And we found that of this group, 44% had got rid of their diabetes at home just by their own actions. Half had used a liquid formula diet, and half, as it happened by chance, had used ordinary foods, but in tiny amounts. The more difficult choice, but these people did it themselves, just pointing out what a simple condition type 2 diabetes is. But then we followed it up with this second study, Counterbalance, and we demonstrated that this wasn't a flash in the pan due to starvation. It was actually a step change which allowed the liver and the pancreas to continue to perform normally, provided weight was maintained and weight regain was avoided. We also showed in Counterbalance that the duration of diabetes was absolutely critical. Long duration didn't necessarily reverse. It seemed like the lights would go out in the beta cell beyond the hope of recovering the mechanisms. We also did a separate study with our local bariatric surgeons and showed the mechanisms were identical following bariatric surgery and following dietary weight loss. There is no magical incretin effect in the immediate fall of fasting plasma glucose. We're still lacking any dramatic impact, evidence of impact of the postprandial incretin spike, which is a bit of a puzzle. And it may relate to the incretin resistance we see at the level of the beta cell in type 2 diabetes. So back to the moor, and here we are cycling across in the early morning and space to take a breath and think. How do we actually move against the ingrained beliefs of the scientific and medical communities that type 2 diabetes was an inevitably progressive disease? Doctors knew that their patients steadily went downhill. And we had evidence from the United Kingdom prospective diabetes study. But what everyone had overlooked was that this downhill path was in people who remained overweight. So how about mounting a large study in primary care, where diabetes is looked after in the UK, and trying to evaluate this using a trusted study design, a randomized controlled trial. Proven methodology, well, the rapid weight loss method with a stepped return to normal eating. My colleague, Professor Mike Lean, had actually developed a delivery system for this rapid weight loss method into primary care, and we collaborated together on DiRECT. It was important that it was based where people were really looked after. And DiRECT at the level of the primary care was not organized by the doctor. It was done by the practice nurse. The nurse was given 8 hours of tuition in how to achieve remission. That's all. Involve other experts. Well, I already mentioned Mike Lean there, and we needed experts to come in and develop methodology for the lipids. And of course, the magnetic resonance technology was absolutely crucial. So getting the technology, the methodology sharpened to the greatest degree is really important. Also, we wanted to really find out how it was for people. So we involved a separate team of psychologists, indeed, same team that we used during the counterbalance study, our second big study, and they carried out their own work. How to do it? Well, the first point I'd make, you need to publish your protocol so that this is the calling card for the study. And here we have our protocol delivered by practice nurse. Now, in Scotland, some practices had dietitians and they did the program delivery. Withdrawing the antihypertensive and anti-diabetic medications, I'll come back to that point, total diet replacement, we use for a variable period of time to take into account personal circumstances. Then this stepped food reintroduction, very critical because people find it difficult going back into the kitchen and cooking again. Then weight maintenance, trying to prevent weight regain. As we'll see, that's challenging. Now, we've got to do some power calculations. How big should DiRECT be? Well, we worked on the basis that if we got a 22% rate of remission, then that would have a clinically useful effect. We assumed that 5% of the control group would find out they were in a weight loss study and go away and do it themselves. It happens. People just behave as humans very understandably. And we assumed a dropout rate of about 25%. Now, there was one step which was really quite important. The primary care doctors were entirely happy to stop the gliclazide, to stop the metformin, stop the other diabetes medications. They really were unhappy about stopping the antihypertensive medications. We discovered this in carrying out the counterbalance study. And so we gathered together the results from the counterbalance study, this is its publication, and showed the GPs what happened to blood pressure when we stop antihypertensive medication, but start the diet. Just look at this. Systolic pressure, bang, down it goes, and at 9 months. Down it goes for people who didn't, the long duration people who didn't get back to normal diabetes control. This is a facet of the weight loss, and the acute drop is probably related also to the sudden drop in dietary sodium intake. Seeing those graphs, doctors came on board, agreed for their patients to be enrolled in the study, and we were going. And recruitment was not a problem, but it's important that you describe the population you're doing. And so we published in Diabetologia the baseline population characteristics. Nearly 300 people, and they were randomized 149 to the weight loss intervention or to best treatment according to national guidelines. Unusually for a weight loss study, there was a slight majority of men. BMI 34.5 and otherwise unremarkable. Now, learning from the counterbalance study, we adopted the recommendation that we should only study people in the first 6 years after diagnosis. This is not a hard and fast rule, but it serves to define a group of people who are most likely to be able to achieve remission of their diabetes. And 1/5 of the population were from the most deprived socioeconomic quintile. In other words, the study was entirely representative of the population. HbA1c 60 millimoles per mole, similar in the controls, and most of them on anti-diabetes medication. I think you may well have seen the results already. So I'll pass over fairly rapidly from the difference between the control and the intervention group in remissions at 12 months, remissions at 24 months, 36%. You'll see way in excess of our best guess line of needing 22% remissions for statistical significance. And indeed, we achieved wild statistical significance. But don't worry about the number of noughts. The statistics are sometimes misrepresented in current medical research. It's the effect size that matters to people. So if we have a relatively small study, this is small for a randomized control trial with 149 people, half of them go into remission. Hey, that is important for the person sitting in front of you in the clinic. If you look at most drug data, the outcome studies, it's pretty so-so on average for the person sitting in front of you. Now, it's dressed up to be mighty impressive, but hey, take a careful look at it. I just want to acknowledge the clinical research fellows who carried out this work, Carl, Svetlana, and also Alison Barnes, Keaton Irvin, dietitians who took part as well in the educational program, and also the Glasgow team. But the one point I'd like to really emphasize is that the remissions were not due to any sort of magic of a dietary composition. Dietary composition doesn't matter. It's whatever suits the individual. Now, of course, for a study, we had to adopt a uniform composition, and that was the one that would suit most people. That's what we did. But what actually happened depended on the weight loss. So not much weight loss, not much remission, either at year 1 or year 2. And you can see if people lost the target weight of 15 kilograms or greater, there was a very good chance of remission at 1 and 2 years. How could you describe this for people in your clinic? Well, you can tell them that if they achieve greater than 10 kilograms weight loss, they've got a 2 out of 3 chance of going into remission. It's not easy. It's not for everyone to do this. And we need to listen to our patients to find out what is possible for people. Because if people are going through periods of stress, then they may not be able to take on this sort of challenge. People may not be interested in taking on this sort of challenge for a variety of reasons. So this is for the people who want to get best control of the diabetes, or ideally to get rid of the diabetes. A surprisingly high proportion of people are desperate to do just that. And that's one thing that diabetes doctors have not been good at listening to historically. Let me summarize the metabolic changes that we saw during DiRECT. They're exactly the same as those that we saw during Counterpoint. Liver fat was surprisingly high in diabetes. It fell to normal. Fasting glucose fell to normal. The plasma, very low density triglyceride, fell to normal, as did pancreas fat, not quite normal, but significant fall. The acute insulin response bounded up, and it was possible to get normal HbA1c. So that's the simple etiology of type 2 diabetes seen in reverse. Moving from diabetes out of diabetes, we know what pathways were affected. It was the same pathways that produced the diabetes. And here is a proof of that concept. Just look at this. The relapses here were in remission at 1 year, but not in remission at 2 years. And you can see plasma triglyceride rose over this period of time back to baseline, delivering it back to the pancreas. So the advantage in pancreas fat, which had accrued in both groups, was lost in the relapses. So we had a ringside seat watching type 2 diabetes develop. There is no doubt about the simplicity of the etiology of this condition, this nutritionally related condition. So what do we see over time? We've just been able to publish a few months ago the 5-year follow-up. Now, this was on the intervention group, and you can see that 46% the remission was weight loss, which was quite reasonable at that time, going down, but plateauing. And although many dietitians can still be heard saying, don't lose weight rapidly or put it on rapidly, that is only so if no action is taken after the weight loss period. But with supportive management, the rapid weight loss is much easier than the death of 1,000 days of starvation, which is the conventional approach to weight loss. Much easier. And you can see that it's possible to be maintained in primary care in large numbers. The remissions. Of course, this, you'll understand from the previous graph, is not enough to sustain remission in large numbers. And yes, we did lose quite a number, but a useful 13% was still in remission. Who was in remission? Well, of course, it was the ones that minimized weight regain. And this group were 8.9, nearly 9 kilograms below the baseline weight. So again, we see the long-term follow-up underscoring the simplicity of this disease. But is it worthwhile? What else is happening? Well, just look at the serious adverse events. We were very keen on documenting these in DiRECT because there was so much antipathy to the rapid weight loss process. It was dangerous, some people said. But this is what I would call an EFI, an evidence-free idea. Look out for EFIs, they're all around us. Look hard at the evidence. Is there really any evidence that rapid weight loss causes problems? Now, of course, it has to be in a nutritionally sound manner, but that can easily be done. Well, no evidence, but look at this. We have very strong evidence that this procedure produces a dramatic effect in halving serious adverse events. Now, here we have the whole 149 of the intervention group. So these are intention to treat data. What can you advise your patient who's considering remission? Well, in addition to not having to take your tablets, in addition to having lower rates of life insurance and holiday insurance, you can be sure that you'll run into less problems causing hospitalization. You can halve your risk. And indeed, if you stick the course and you're part of the group who were followed up to 5 years, it's even better. So this is a serious matter for gain of health. So you might say, there we have it. Type 2 diabetes, so simple, due to excess fat. But is it due to obesity? Well, therein lies a tale, because it was very clear to us that the slimmer people had shown exactly the same underlying mechanisms as had the heaviest people in getting rid of their diabetes. At the same time, we had many slim people asking if they too could lose weight. Now, because I'd had personal experience of looking after slim people who were desperate to get rid of their diabetes, and I had suggested this to them, I knew that at least some people would get rid of their diabetes. But is this a real phenomenon, and how many? Well, we actually wrote up this phenomenon, myself and Rory Holman, using UK PDS data, which Rory has particular access to, putting together this hypothesis, as it's overlooked that in UK PDS, there were very few people who were obese in our current definition. And indeed, 25% had a normal body mass index. This is the group from whom we've got most information about longer-term aspects of type 2 diabetes and the value of control. So how does it look if we actually take this possibility that in fact there's an individual personal fat threshold some people will get metabolic effects at a lower fat level than others. Well, to cut a long story short, we looked at a group of people with body mass index of 21 to 27. We found their liver fat level was 3-fold greater than normal, exactly the same fold increase compared with the heavier groups. The VLDL triglyceride was approximately 1/3 elevated, and with weight loss, it fell to normal. HbA1c normalized, but let me just emphasize that over the 1-year follow-up, keeping the weight steady, look at this, HbA1c improved. And this is due to the steady improvement of beta cell function we have documented and published on, such that the total functional beta cell capacity is back to normal at 12 months. There was no death of beta cells. There was no apoptosis of beta cells. They were actually still alive, merely not functioning. So in RETUDE, 70% achieved remission. This is added up to a national program in England to produce remission, and the first year data in a large number of people showed 10.3 kilograms weight loss. This is probably the largest low-cost population intervention to deal with a weight-related problem. How can you find out information on how to do this? Well, this is the website which was put up to advise patients, people with diabetes, but also there's a section on it advising doctors in detail. It's also written up in a book form for people with diabetes, but I wrote it with a subtext for doctors too. Incidentally, all proceeds go to Diabetes UK, which is a charity that had the foresight to give the research grants to carry out this work. It's been translated into German and into Dutch. And that takes us to the bottom line. Here we're back on the town moor in the early morning of a February day. It's very atmospheric. You can see the space to think, just an aeroplane floating overhead, and the sun's rising in the upper windows of the old military museum in the corner of the moor. And how does this all look from this perspective, putting it all together? Well, I hope you'll agree with me that type 2 diabetes is caused by excess fat in the liver and pancreas above a personal fat threshold, nothing to do with body mass index. And using effective weight loss, it's possible to restore normality for people who want this. Thank you.
So thank you very much, Professor Taylor, for sharing your inspiring work and also for the really exciting talk. I don't know if we have any questions from the audience. Of course, you have touched many interesting points and recapitulated all the pathogenesis of type 2 diabetes. So I guess someone will raise an hand. Let me see. Otherwise, my co-host and myself have a lot of questions for you. Okay, we have a question from the audience. So it says, "Thank you for this wonderful talk. I was wondering whether individuals were truly on 800 kilocalories for more than 1 year." I think that's an interesting question.
Thank you. Yes, this is really important. Thank you. I should have made it clearer. What we're looking at in getting rid of type 2 diabetes is a step change in weight. The 800 calories is purely to achieve this journey from A to B. And so it is a weight loss diet. And it's easy to do for the reasons I mentioned, but also people don't suffer unduly from hunger. Quite remarkably, when you go under 1,000 calories a day, the sensation of hunger is very much reduced. So it's a means to an end. It's a change of state. After that, people have to realize that they need to eat only about 3/4 of the total amount they used to eat. Now, small animals don't need as much to eat as big animals. And of course, these people have changed their body size. They no longer need to continue to have all these tissues metabolizing. And for that reason, they need to adjust to a different intake of calories. So no, they don't stay on the 800 calories at all. They go back to initially to round about 1,600 or 2,000 calories, depending upon their level of activity, their size. But how much they eat thereafter is dependent upon the absolute measure, which is weight. And so it has to be self-adjusted. Thank you.
So just a quick question in line with the previous one, because I've just read a recent population-based study from people in Oxford showing that among people living with overweight, even in the UK, these total replacement diets are by far the least preferred ones. So, and I think this was somehow expected, I guess. And so I was afraid that this could actually reduce the clinical impact of this intervention. So should we just like give up on the opportunity of pursuing diabetes remission in those people?
Right.
Or should we try alternative?
This always makes me smile because it's a matter of how you phrase the question. If you say, would you fancy just having liquids and getting way back to 800 calories a day? What do you think about that? That sounds terrible. But if you explain, look, you really need to shed 15 kilograms, 33 pounds. It's a lot of weight. The easiest way to do it, and the one that will cause you least hunger, is to do it quite rapidly. To do this, we use a special diet whereby you don't have to worry about what you're eating every day, because it's all given in the form of a liquid diet, and people find it very acceptable. So the doctor has to be really aware of these advantages, and I would point out our qualitative papers I didn't refer to in the talk. The first name author is Rehakova, and she documented the liking of the diet in the counterbalance study, and also this was reproduced in the DiRECT study. The Oxford study is merely a matter of asking people if they fancy a starvation diet. Oh no, I don't fancy that. You see, it's a silliness. But if we're serious about achieving weight loss, we have to take an effective way. Now, which weight loss diets are effective? If you look at the history of weight loss diets, it is pathetic, absolutely pathetic. And to have someone publishing, hey, look, this method works in all comers who volunteer for the research, all comers in 5 successive studies now. What? 15 kilograms and it'll line up in 5 studies? No, surely not. These are funny people. No, it's a matter of the effectiveness. So I frequently run into this problem in talking to doctors about it. And they say, oh, I wouldn't want to do that. And of course, it's the same sort of impact. So doctors have to be aware of the properties of following this diet, be aware of the effectiveness of this method, and to open their eyes to what we all want for our patients, an effective method. So I would point out that we can administer questionnaires till we're blue in the face, but it doesn't actually cut any ice. If we're going to grasp the facts of nature and use them to the advantage of our patients, then we have to just be more widely aware and also aware of the human element, because we're not purely measuring biology. Any phenomenon we look at is partly biology, partly human. and appreciating that people are humans interacting in a social environment. It's vital to being doctors and being able to persuade. So I think those are really important points. Thank you.
Thank you, Professor Taylor. So they're coming up with many other questions. One of them is, do the people stop the trial need to restart the medicine?
No, no. Once they have lost the weight, then 46% of them were entirely in the normal in the non-diabetic HbA1c range, and they did not have to restart the medicine. Some people were still in the diabetic range, but were sufficiently well controlled that the doctor said, okay, that's fine. Most of those people went back onto metformin, but everybody went on to less medicines that they were on before. So even the people whose HbA1c had only gone from, say, 68 down to 58%, then yes, there was an advantage for them. But medicines, no, it's possible to stop the medicines entirely. Metabolism has gone back to normal function.
So there is another question. Sandra, please.
Thank you. Thank you very much for this interesting talk. You showed us a graph with the responders and non-responders and their blood pressure at baseline and during the study. And I was triggered by the fact that the baseline systolic blood pressure of the non-responders was already higher compared to the responders. So is this something that you now could use as an indicator of not being suitable for this type of treatment?
Okay, so brilliant question, thanks. The reason we started taking notice of blood pressure was that in the counterpoint study, we had a couple of people who experienced postural hypotension. And when I actually went over the blood pressure data with ELIM, it was quite clear we'd had quite a sudden drop. And so we prospectively either stopped or reevaluated people's blood pressure treatment in that first study. For the second study, we stopped all medication at the onset of the study. And so these are the data you comment on. And you're absolutely right. If people are on 2 or more agents, then the blood pressure is higher. And that was a group that didn't stay off the agents. Now, in our national program for England, the NHS program that's running now, we've modified the original approach, and at the onset of the diet, we drop 1 antihypertensive agent, the one that is most suitable to drop, which inevitably is the one that's most likely to cause side effects for that individual person. So I would now rephrase my advice and say, at the onset of the diet, stop 1 tablet for hypertension. And just while we're on the subject of tablets, I'd like to emphasize that we advise people to stay on the statin because we do not have long-term data as yet from this approach. There's some interesting data from other studies, but we need to be cautious. Hippocrates, at least do no harm. We just need to be very cautious. So stay on the statin, but blood pressure tablets drop 1. I hope that answers your question.
Yes, thank you.
Thank you.
Okay. We've got several questions from the audience. I'm trying to summarize a couple of them. So a few people are asking some more details about your personal fat threshold hypothesis. In which ways this differ from the adipose expandability hypothesis, and whether there are any diagnostic tools or interventions to translate it into the clinical practice.
Yeah. We tried to look for prognostic tools during the RETUNE study. We looked at a range of adipokines, inflammatory mediators released from adipose tissue, we did not find any distinct indicator. What we can say is the reverse. If a person has high glucose and raised triglyceride or high normal triglyceride, then they'll likely have a high normal or raised liver enzyme, especially ALT, alanine aminotransferase. And so the normalization of those factors are the best guide to when the personal fat threshold is crossed. But I'm afraid all I can say is that we can only deduce that a person has a personal fat threshold between the level at which they have diabetes and the level at which they're shown to be free of type 2 diabetes. And it's very variable. And amongst the happiest people in remission are those who are told by the doctor, you mustn't lose weight because you have a normal BMI. Now, anyone with any knowledge of how population normal numbers work would see the fallacy there. If I, a thin guy, was to put up my BMI to say 23, I would likely be metabolically obese just because I am where I am. It's my body shape. So we have to move away from thinking in these epidemiological ways because population science does not work well in the clinic. So personal fat threshold, no, we can't measure it precisely, but the concept is grabbed by two hands and welcomed by people who say, why have I got type 2 diabetes? My friends are all fatter than me and they don't have it. And they get it immediately. So it's really useful. It's a useful tool for doctors to explain.
Thank you.
And one last group of questions about physical activity in such very low calorie diet. How does it fit together? How it works together with physical activity, which is important by itself?
Sure, this is a really important question. First of all, the people who are in manual jobs, burning quite a lot of energy, did absolutely fine on the low-calorie diet. Let me illustrate that further by telling you an anecdote. I continue to get lots of emails from people asking odd questions, and one of them about 6 months ago was from a man who said, I'm 55, I've just got diabetes, I read it on the web about your approach, and I've started on that, but I have a question. My hobby is running ultra marathons. This man runs ultra marathons, and he ran 30 miles, what's that, about 40 kilometers over mountains as his event. And he wanted to do a competition in 6 weeks' time. And he wanted to know if he could continue the diet up to the competition or not. Now, I had to get out a pencil and paper to work out the energetics. And I said, yes, carry on with the diet, except 24 hours before the event, please build up your carbohydrate intake and have a normal run-in to the race, because I knew that he would be depleted in his glycogen stores. I also knew that they would replete very rapidly. And I said, this is all theoretical advice. It's the best I can do. So please let me know what happened. And I got the happiest email saying, it was magic. I've got a personal best. Now, what had happened is he dropped 2 stone. That's what, 14 kilograms, 13 kilograms thereabouts. And he was running over mountains that weight lighter than he was used to running, because he wasn't a high-level athlete. He was just a hobby runner. So that tells us everything we need to know about energetics. We don't need the constant incoming carbon in order to keep us alive, but to change weight as we want to do is actually an advantage for people to be very active. However, big caveat, please advise people not to start an exercise program at the same time as a diet. This is probably the best kept secret in the whole of weight management science. Compensatory eating kicks in. You may well have friends who've said, well, I joined a gym and I sweated away for 2 months, but my weight was actually going up. I don't understand what's happening. Well, this is compensatory eating, and it's partly conscious, but it's mainly subconscious. So yes, weight loss is dietary and exercise is helpful, but not at the same time. We have to just see that moving these two apart in time is a really good move. So yes, we advise no additional exercise during the weight loss period. Just carry on with whatever exercise is done. Afterwards, we open up the throttle on advising more day-to-day physical activity, taking up any sort of activity that they enjoy doing, which is the best way of activity being sustainable. So the activity question is really important, but please don't advise them both at the same time. This is the human aspect of what I was talking about before.
So thank you so much. I've got another question. This is from myself, because I mean, from someone who truly believes in the potential health advantages provided by this sustained weight loss and diabetes remission, like reading the 5-year results of the DiRECT trial was a bit disappointing, but still, I wonder, based on the look-ahead findings and also our knowledge on the glycemic glucose legacy, whether we can still expect some long-term benefits associated with this transient diabetes remission, and of course, if you have any data or thoughts about them, it'll be nice. Thank you.
Okay, this is a really important question again. Thank you so much for this. You have to understand that the DiRECT study was set up to be almost zero cost in the British National Health Service. So the follow-up was a mere 3-monthly visit. If you look at the look-ahead study, for instance, it was intensive input, very expensive study, that's fine, but we were trying to look at conventional management. Now, we obviously need a more intensive follow-up management to help prevent weight gain. In the delivery of this, remote delivery using IT systems have been surprisingly effective. Now, you'll be aware that the follow-up of DiRECT happened during the COVID epidemic. That was a further disadvantage. Some people, interestingly, found it easier to be at home away from the temptations of the coffee shop. Other people found it more difficult and they were raiding the fridge. But it was a complication, but it allowed us to test the IT delivery of service, and it's very good. So I think first point I'd make is that we do need better follow-up. However, there are some other points. We had been relying upon the routine care staff, the practice nurses, to deliver this. But the practice nurses turn over, new ones are appointed, they change jobs, and the highly motivated, educated, experienced lot that did the first 2 years of the study actually were not doing the follow-up. And we used rescue packages. I didn't talk about those, but if people put on weight more than 4 kilograms, they were offered the chance of going back on the low-calorie diet. And they were not offered to any great extent. So there were problems in the delivery over years 3, 4, and 5. So that has to be borne in mind. It's not an excuse, it's just how things were. But hey, look at the benefits. Those differences in side effects were huge. And let me just point out that there were 8 cancers in the control group. All of them were weight-related cancers, known to be weight-related. How many cancers were there in the weight loss group? 1. 1 versus 8. Now, these numbers are too small to make a statistically significant statement, but hey, that ratio is huge. And who was this one who got the cancer? It was actually someone who dropped out quite early, possibly didn't even have the weight loss. So that 8 versus 1 again, is an intention to treat. So is there a benefit? You bet there is. And finally, the look-ahead data was mentioned. Now, please read that paper reporting the 12-year data from look-ahead on remissions. The people who were in remission for more than 4 years had an approximate, well, it was greater than 50% reduction in heart disease, chronic kidney disease. But if they're in remission only on one occasion over those 12 years, they had a 33% reduction. That is huge. That's a bigger effect than the statin effect. Hey, there's all sorts of messages in here. One is yo-yo dieting is bad for you. That's an effie. It's complete nonsense that's been put about with any sort of insight. Getting the weight down substantially for a variable period of time confers long-term benefit. Whether this is metabolic memory or something else, we don't know. But I would say the 5-year data need to be looked at carefully in detail and thought about, because we can do much better than the DiRECT, rather sloppy follow-up system. And we know that even with that sloppy follow-up system, hey, people did better. And our oncology services have got at least 7 less people in than they would have had otherwise.
Thank you. Really wonderful reply. So I don't know if we still have time for other questions, also from the audience. I don't think we are doing justice to your questions. So please step up and talk yourself if you like. Okay. There are other questions related to the kind of diet, but I think we covered many aspects of the intervention. I don't know if Rumiana has other questions for you.
Yes, I have just one short question. If you get the chance to redesign the DiRECT study, will you change something?
I'm sorry, I was trying to take it in the chat questions as well. So if I got the chance to repeat, what was that, Fiona?
If you get the chance to redesign the DiRECT study, will you change something in the intervention and the whole?
Yes, I would have the intervention provided by health educators who are trained in the study. It is so simple. We don't need a nurse, we don't need a dietitian to deliver it. Some dietetic information is useful, but that can be summarized quite easily. I would be relying much more on an IT delivery system. And I think those are, those are the 2 big things. A lot I would keep the same. The rapid weight loss, it's humanly possible. That's how we can achieve weight loss in clinical practice. The previous weight loss studies, have a look at them if you don't believe me, but they were cheering at weight loss over even a few months of 3 kilograms, 4 kilograms, really very poor. I probably ought to mention that the new weight loss drugs can be predicted to produce exactly the same effect upon diabetes as the dietary weight loss at huge expense and some side effects. So there are big problems there. And of course, they don't educate families as to how to eat, because this approach has the effect of helping the spouse. And almost always when the spouse came up, they'd be sitting there with a smile on their face. And when they had a chance, they would say, "And I've lost weight too, doctor." So, there are major advantages to doing as we did. So to summarize, yes, more intensive, longer term follow-up using a low-cost health coach approach and using IT.
Okay, so I think we can say we are all very grateful to Professor Taylor, and we're really looking forward to your talk at the ESD. So many congratulations on your Claude Bernard lecture. I know it's a big but also very well-deserved achievement. So please join us in a warm applause to Professor Taylor. And again, thanks everyone for joining us this afternoon.
My pleasure. Thank you.